Hi guys, in this video I'm going to discuss a slightly amorphous topic, infectious arthritis. So unlike a lot of the videos that I've done, this isn't really one condition or one organism that's causing a very specific readout. It's kind of a collection of organisms that manifest themselves as arthritis, and they're caused by a wide variety of pathogens. So when we think about infectious arthritis, really what we're thinking about is infection of the joint. That's all it means. It's just kind of I guess, somewhat fancy way of saying that. And it goes by a lot of names, including septic arthritis, pyogenic arthritis, suppurative arthritis, purulent arthritis, and pyarthrosis, if you really want to get technical. Technically, septic arthritis would really only refer to arthritis that is caused by bacterial infections or fungal infections. And for all of the infectious arthritides, we're really talking about when the bones have been infected by either a bacteria, a fungal infection, or a viral infection. Those are the ways we actually see infectious arthritis. When we think about infectious arthritis, the kinds of patients we're thinking about, typically we're talking about kids. Kids are a lot more likely to get infectious arthritis. In fact, more than 50% of the cases actually occur in people less than 20 years of age. So that kind of gives you a bit of a way to narrow it, but that isn't to say that adults can't. I mean, we've talked about organisms already that we certainly expect to see more often in adults than we do in children. And one of those would be like tuberculosis, which can lead to arthritis. And then some of the sexually transmitted infections, which we haven't talked about yet, but we will talk about in your M2 year, also lead to infectious arthritis. So those certainly we expect to see in sexually active either adolescents or adults. Okay, so I said that infectious arthritis was due to infection of the joint. So first we have to figure out how are we going to get a measly little microbe who's maybe like hanging out on the skin into the actual joint to cause the infection. And there are kind of three broad ways that this happens. The first one I'm going to talk about is hematogenous spread or hematogenous spread. This is the most common mechanism by which microorganisms enter the joint. Now, if you think about a joint, and obviously Dr. Wilson can describe this a lot better than I can, there's this synovial fluid, which is pretty much devoid of cells, and the joint space itself is referred to as the synovium. And there's also the synovial membrane, which is really highly vasculature, and that's what, this is supposed to depict here, all these blood vessels. It's got a lot of vasculature to it, and there's and that's part of the connective layer that kind of holds it all together. But there's no basement membrane, and that's actually important when we think about organisms getting in. When there's no basement membrane, it kind of lacks that physical barrier that will keep organisms out that we have relied on in other body systems that we've talked about, like say your gastrointestinal tract, or we haven't talked about it yet, but your blood-brain barrier. So it lacks this really tight physical barrier that might keep organisms out. And the lack of this basement membrane combined with the significant vasculature is actually what facilitates the organism actually getting in. So anytime a organism is in your bloodstream, so let's say we get bacteremic, and we get bacteremic numerous times a day, but if you have a significant bacteremia, then the organism can pretty much travel in the bloodstream past this basement membrane and directly into the joint space. So how does this happen? Typically, patients are going to get bacteremic from just all of the other reasons we've talked about throughout the curriculum for getting bacteremic. So an upper respiratory infection, a gastrointestinal infection, or even, we've seen it with like bowel perforations we've talked about a little bit. And also skin infections, right? We talked about that, specifically skin infections from, say, IV drug users, where we take organisms that typically live on the skin and then kind of inject them into the bloodstream because maybe it's not as clean as we need to be. The other way that we sometimes see patients contracting bacteremia would be through surgery, specifically surgery involving the joint, or a joint injection, which is actually something we'll talk about in the next method. So these can all contribute to bacteremia. And anytime you have instrumentation, right? So we talked about that a bit when we talked about endocarditis. So patients who have endocarditis, remember, anytime you have a patient with either acute or subacute endocarditis, that means they have that vegetation on the valve. And that actually means that they are kind of constantly bacteremic, right? Because the vegetation is going to constantly kind of be leaching some of the organisms away from the kind of biofilm out into the bloodstream, which can then go to your joints. So any of those organisms we certainly want to consider. Okay, so then the second way that we consider when thinking about routes of infection of a joint would be direct inoculation, which is kind of what's shown here. They're calling it diagnostic or therapeutic procedures or local soft tissue infection, but really the way we refer to this, it would be direct inoculation. And really what this means is we're directly injecting the causative organism into the joint right there. So this occurs when the joint is contaminated, either through a sharp object being injected, like a needle, or even something silly, like crawling or scooting or kneeling on a sharp object. And again, we can attribute this to joint surgery or joint injection anytime we have things injecting near the joint area. Okay, the last one that we're actually going to talk about is contiguous extension. And I'm kind of highlighting this adjacent osteomyelitis because that's actually more what we're considering with this. So in this case, you have infection of the actual bone here. And then the bone itself is actually kind of invading the joint space, and that's allowing for seeding of this infection into the joint space. So you already have this infection. It's associated with osteomyelitis and will occur adjacent to osteomyelitis. All right, so then we don't really need to think too hard about the immunopathogenesis surrounding bacterial arthritis because it really is the same as every other bacterial infection we've ever encountered. It's really just that it's happening in a much smaller space, right? So if you think about your joints, and I am no artist, but let's say this is one bone and here's another bone. If Dr. Wilson watches this, he's going to be laughing at me. And this is kind of our space around the joint, and maybe there's some fluid in here, okay? And then we've got, your vasculature, which is coming in, surrounding it, okay? And like all vasculature, it has, the endothelial barriers surrounding it. So most of the time, the cells just kind of whiz by, right? But in this case, you've got some sort of organism happening. So maybe it came in through your mucosa, right? Where you had an upper respiratory infection, much like I have now, and it goes through the epithelium there, breaking through somehow, gets picked up by macrophages or PMNs, most likely neutrophils. And in that case, most of the time, your body, and hopefully mine right now, is going to control it, right? So macrophages producing IL-6, which will induce Th17. We'll also have some Th1 cells, which will produce interferon gamma, which will help our macrophages kill it. And hopefully it just stays right there where we like it to in the upper respiratory tract. Okay? But in some cases, you either have that it gets into that bloodstream and then somehow into the actual joint space itself, or could be carried there in some sort of monocyte, okay? So they have it listed here almost like it's the same as a macrophage, but you guys know better, right? Because you know that macrophages are tissue resident. So let's say this is a monocyte, all right? That this organism happened to be infected in the infect the monocyte or just carried in with the monocyte. And now the bacteria are out in the joint. Well, at this point, we're still going to have the same effect. We're still going to have osteoblasts secreting IL-6 and TNF-alpha, basically calling for help, right? They're just going to create inflammation.
and that's going to induce macrophages to secrete TNF-alpha. It's going to induce the Th1 phenotype and the Th17 phenotype. The Th1 phenotype is going to secrete interferon gamma, which is going to license these macrophages, now that they're in a tissue site, to kill. The Th17 is going to secrete IL-17, which is going to recruit some neutrophils. And you guys know that once neutrophils show up, all bets are off. The whole house is burning down. Now we've got significant inflammation, right? Because the neutrophils are going to produce, pro-inflammatory mediators, cytokine, as well as prostaglandins and leukotrienes that are basically going to further weaken this vasculature, allowing for further inflammation into the joint space. And eventually the joint will swell and that will become red. And eventually this increased pressure on the joint might actually interrupt blood flow. And depending on where that is, particularly if we're talking about near the femoral head, you can actually get avascular necrosis if the blood is cut off significantly enough. Okay, so that's kind of the concepts behind bacterial arthritis, but let's talk about some of the causes of bacterial arthritis. So by now you should be used to seeing Staph aureus pretty much everywhere, and this is another place where we might see it. And we actually do know a fair bit about what causes bacterial arthritis, because about 50 to 70% of bacterial arthritis cases can actually be identified. And they're identified in two ways, either by performing cultures on the synovial fluid or by doing some sort of gram stain or PCR at the site. So you can look at cultures, you can look at PCR, you can look at gram stain, just depending on what the organism is that you're looking for. And you're really going to look at the synovial fluid. The synovial fluid in a bacterial-induced arthritis should be pretty chock full of organisms. And in fact, in some cases, that might be the only place that you can find the organism. In other cases, you might be able to find it in the blood, particularly if it was brought there by hematogenous spread, and if you're at the right time to identify the organism there. So Staph aureus is actually the most common cause. It's detected by culture in all age groups, and sometimes it's actually associated with venous thrombosis or pulmonary disease. So you sometimes have to kind of think of it in other settings. The other thing that you should keep in mind is, remember I mentioned that we can sometimes see arthritis with bacterial endocarditis, so SBE, or even acute bacterial endocarditis, so I'll just say EE or IE. In these cases, it is possible that arthritis might be your first presenting symptom. So if you find a case of bacterial arthritis that's due to enterococci or staph or something else in a patient who you think might be high risk for these, you might consider kind of just making sure that these aren't also occurring in that patient. There are various streptococci that cause bacterial arthritis, specifically group A strep, strep pyogenes, which is kind of the causative agent of strep throat in most cases. That occurs in patients who are 5 years old or older most often. Group B strep we haven't talked about yet. Group B strep we're going to talk about in your sexuality and reproduction block in your M2 year. This is a form of streptococcus that actually colonizes the vaginal tract of women and can cause significant problems for infants. So typically we see this in patients that are less than 3 months old because they contract it as they come through the birth canal. Strep pneumonia, we do see strep pneumonia as a cause. Typically, we see this in patients who are younger than 2 years old, and they have not typically received the vaccine yet. Or if they have received the vaccine, it doesn't include the 13, it's a serotype that is not included in the vaccine that's causing it. Kingella kingae, this is another one of those ones that I brought up. It was one of your HASEC organisms for the SBE or BE, and we do find that in children younger than 2 to 3 years of age. We also find it as a cause of bacterial arthritis in adults. Haemophilus influenza type B, another cause of osteoarticular infections in young children, particularly in those who are unimmunized or underimmunized if they haven't completed their course. Gonococcal arthritis is actually kind of an interesting one. This is an important cause of septic arthritis in two kind of types of people: newborns and sexually active individuals, particularly teens or adults, obviously. So in newborns, you've got kind of this prodromal symptom that is nonspecific: irritability, fatigue, failure to eat, things like that. And then you can kind of further narrow it down based on where the pain is. Pain is typically seen in joints below the hip. Those are the joints that are most often involved with gonococcal arthritis. When it is a cause of sexually active adolescent bacterial arthritis or adult bacterial arthritis, it's actually due to a disseminated infection. And sometimes arthritis is the only sign that this patient has a Neisseria gonorrhea infection. And when it does, it often causes a migrating arthritis. So when Dr. Goodman used to teach this to our M2s, he would say, sometimes you'd have, a young 20-something in your office saying, yeah, my knee is really killing me. It's been killing me for, a week or so. And actually, before that, my shoulder was hurting. And then, my right before that, my wrists were killing me, and I blamed it on carpal tunnel. And you listen to these various joints that are being affected, and maybe you can identify some sort of fever, chill, polyarthralgia that is going on that then can make you narrow down to gonorrhea. And in these patients, they might not have skin lesions, and they might never have, they might not have been aware of it, but they'll have some of those other symptoms that kind of predated the arthritic symptoms. So that can actually be kind of an interesting one. We talked about Lyme disease back in your Leah Smith case. So remember that we do see arthritis in the later stages of Lyme. We're not entirely certain why, but we do see an acute monoarthritis that should be considered in any patients who have been in an endemic area. Hopefully you remember where those are. You're probably sitting in one right now if you're at school. And others who present with other Lyme symptoms. That would include like your erythema migrans, fever, and particularly the arthritis. And once again, we're going to diagnose that by serologic testing. Tuberculosis can cause an arthritis. This should be suspected in patients with a persistent culture-negative oligoarthritis or monoarthritis in a setting of relevant epidemiologic exposure or in a subgroup of patients that you're concerned about, right? So patients who have recently traveled, patients with reduced cell-mediated immunity, anybody who's had a positive TB test. These are patients we might be concerned about. Secondary syphilis. Now, this is kind of, I have a question mark here. We do see arthritis in syphilitic infections. We haven't talked about syphilis yet, nor have we talked about Neisseria yet. Again, we're going to talk about those in your sexuality and reproduction block because they are sexually transmitted infections. Syphilis is actually caused by the organism Treponema pallidum, and it's a multi-stage infection, kind of like Lyme disease. And in the second stage of syphilis, some patients may experience a monoarthritis. So I keep it on the list, but it's kind of a question mark because it's not a common symptom. Now, I also have these other two, and I'm not going to go into much detail on them. There are fungal infections and viral infections that seem to cause arthritis. The fungal infections are caused by, the fungal arthritides are caused by sporotrichosis, coccidiomycosis, candidiasis, and several others. And once again, you're just going to diagnose this using a fungal stain or culture of the synovial fluid. The viral arthritis, we've covered some of these. So remember we talked about like dengue, which is that break bone fever. And we also talked about chikungunya. Both of those certainly qualify as viruses that cause a infectious arthritis. Zika would also qualify here. Zika can cause a fairly significant arthralgia. And then there's also parvoviruses and rubella viruses, which we will cover more in your M2 year. So as far as kind of take-home points, you want to kind of be aware of the major organisms, so certainly Staph aureus, Streptococci. And even though we haven't covered it in depth, I do want you to recognize that Neisseria can cause bacterial arthritis in both newborns and sexually active adults. And specifically Lyme as well. Lyme is kind of one of those ones that we chase, and sometimes arthritis is kind of one of the ways we identify that a person previously was infected with Lyme. Any organisms that we didn't cover in depth, don't worry too much about the normal bacteriology that you normally cover. We'll cover that later. Good luck.